Shall we start, ma'am?
I think we'll start.
Yes, ma'am. So, very good evening, doctor. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is hormonal imbalance and insulin resistance in PCOS. I welcome all the participants. I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our expert speaker for the day, Dr. Charmila Ayyavoo, ma'am. Madam is currently the director of Aditya Hospital and Parvati Ayyavoo Fertility Center, Trichy. Madam is currently the vice president elect of FOXY 2024, chairperson, clinical research committee FOXY 2016-18, ICOG governing council member 2021-23, national coordinator UNICEF FOXY PCA, national coordinator for Ameda FOXY PG program, a national coordinator for ISAR Gurukul 2022. And Madam is the past secretary of Trichy OG Society, president Menstrual Hygiene Management Consortium 2018-20, and also the joint secretary of Gestosis India Association. So with this short introduction, I welcome you, ma'am. I'm welcoming you for your presentation, ma'am. Thank you, ma'am.
Thank you, Dr. Stalin, for that kind introduction. Thank you so much. I'd like to thank Shield Connect for the opportunity. And this is a very dear topic to me, and that is the hormonal imbalance which happens in insulin resistant PCOS. The thing is, we know that PCOS is a it involves every specialty now, and it is a disease which needs to have always a multi-pronged strategy to manage it. And even though we deal basically with infertility and the abnormal uterine bleeding, and sometimes the endometrial cancers and hyperplasia, which can happen because of PCOS in a lady, we need to know what is the basis for this, because the hormonal imbalance which happens in a polycystic ovarian disease patient is something which is quite unique, because it can happen. It's a vicious cycle. It starts somewhere. Nobody knows how it starts and when it starts. But once it starts, it is there throughout, and it becomes there's a genetic predisposition also. And they also attribute an epigenetic change which can happen with your lifestyle, and that's going to program this disease into generations after generation. And it's quite easy to break this disease if you can follow the proper lifestyle and manage yourself accordingly. So the introduction to polycystic ovarian syndrome, it's a complex endocrine condition. That's quite clear, because it can happen at the pituitary level, it can happen at the ovarian level, it can happen at the other peripheral tissues. But when it comes to a lady in the reproductive age, the prevalence is almost like 15 to 20%. Such a high prevalence is there. It affects the whole life of a woman, as I said, from the young adolescent to the older patient. It can happen in any age group, and it can begin in utero. And actually, the antecedents are in utero itself. It's not something which you acquire later. Can happen in utero in genetically predisposed subjects, and can even have a paternal line. It's not only the maternal line which can predispose one to have polycystic ovarian syndrome. It can be the paternal line also. And how does it affect a lady? It can present clinically at puberty itself, like amenorrhea can happen. She can have irregular menstrual cycles even at puberty, and once it sets in, it continues during the reproductive years. And in the reproductive age woman, it's a major cause of anovulatory infertility, because ovulation does not happen and the lady goes for infertility. And the diagnosis, still there's lots of controversies happening with the diagnosis of PCOS. But as an obstetrician gynecologist, we always base our diagnosis on the Estradiol Rotterdam consensus meeting in 2003, and which has now been updated in 2018. And this is actually based on the previous NIH classification of 1990. The etiology, as I said, is not completely understood yet, but we know it's a multifactorial disorder. It can have a genetic component, it will have a metabolic component, it has an endocrine component, and environmental abnormalities also. So these are the clinical features that are commonly seen with the polycystic ovarian patient. They can manifest with central obesity, they will have hirsutism, they can have acne, they can have a male pattern baldness, and acanthosis nigricans is quite common when there's insulin resistance. So the clinical manifestations is when the lady is exposed to a disease like polycystic ovarian syndrome, she's got an increased risk of cardiovascular disease, an increased risk of hypertension, diabetes, and other metabolic complications. And usually, even it starts in an early age and will always manifest around menopause in most of them. And during the fertile period, it can cause annular infertility, as said before, and that's going to cause an increased prevalence of gestational complications, and that is miscarriages, gestational diabetes, and preeclampsia are quite more common in a polycystic ovarian disease patient. And what is the etiopathogenesis? Whatever it is, all the guidelines, everybody agrees that the basic factor in polycystic ovarian disease is the exposure to hyperandrogenism, and the antecedent starts even in utero, and which can lead, that is, a maternal hyperandrogenism is going to cause the baby to be exposed to this androgens, and that can cause epigenetic reprogramming of these babies, which can translate into a phenotype of PCOS in adulthood. And if these alterations are persisting in the germ cell line, it's going to be a transgenerational transmission to the next generation, because it started somewhere in one mother. And all the other genetic factors which are linked to insulin resistance, and a postnatal environmental factor like a diet which can increase the chance of having obesity, it's going to increase the chance of developing PCOS phenotype, and this will be in association with other epigenetic anomalies. So what happens is, in the maternal ovary, there is an increased production of androgens, and when this mother becomes pregnant, the fetal ovary is also exposed to these type of androgens. So there's going to be a prenatal, prepubertal hyperandrogenism, because when the mother is having, it's going to cause the baby to be exposed, and when the fetus is exposed to hyperandrogenism, it's going to cause a prepubertal hyperandrogenism in these girls. And they will have a predisposition to have central obesity, that is, the central area becomes more. And when they have central fat, it's going to contribute to insulin resistance. It's very important, because even the so-called lean patient can have an increased central fat, which is contributing to insulin resistance. And they will also have anovulation. Both are equally there, insulin resistance and anovulation. A person is lucky enough, they may not have one or the other, and that may be causing a milder form of PCOS, but most of them will have, almost 60 to 70% will have both anovulation and insulin resistance. And it's basically because of the regulation in the genes, which is going to affect the insulin secretion, the insulin action, and there's going to be a differentiation of the fat cells, the adipocytes. So all these are going to cause an increase in the insulin resistance. And anovulation is because the genes are going to get regulated, which is causing an affection in the follicular genesis and steroidogenesis. So basic factor is always hyperandrogenism. And when there is central fat more, it's going to cause insulin resistance. And when the fat tissues are going to be more, anovulation is also going to be more common. So there's another link between a fetal origin and when adult disease of polycystic ovarian disease, because suppose the baby has been growth restricted, it's got a growth restriction. These children are known to have an increased risk of metabolic disease like type 2 diabetes and cardiovascular disease when they become as adults. And so that's why when a baby is born small for gestational age or growth restricted, there's already an adverse in utero environment for this baby, which predisposes to insulin resistance. And when the mother thinks that the baby is born small and she tries to overfeed these babies, they're going to have long-term effects on obesity, insulin resistance, and a predisposition to disorders of glycemic regulation. That's why when a baby is born growth restricted, small for gestational age, it's better that the parents do not overfeed these child, and they advocate increased physical activity with a lesser form of carbohydrate diet, so that these children do not manifest these metabolic diseases as adults. They have to keep their lifestyle in check. And also, suppose the mother has been diabetic during her pregnancy, it's going to contribute to a higher incidence of childhood obesity in her children, and they're going to have a higher incidence of impaired glucose tolerance as adults. That's why fetal origin of adult disease can be applied to polycystic ovarian disease always. And the other endocrine factors which are affected in PCOS patient is the ovary also, and that may be because of both extra and intra-ovarian factors. And when there's a disturbance of this equilibrium between these two factors, it's going to alter and compromise the follicle development and the formation of mature oocytes. That is because the equilibrium changes, and that's going to cause not only an anovulation, it's going to cause a damage to the mature oocytes also. And that may be the reason that these patients are more commonly have miscarriages. So what are the extra ovarian factors which can be altered in a person with polycystic ovarian disease? It can be a deficit in the FSH, the follicle stimulating hormone from the pituitary, or there may be a hypersecretion of LH, or there may be more of androgens which can be of ovarian and adrenal origin, and the hyperinsulinemia with insulin resistance. All these hormones are going to contribute to a change in the milieu in a polycystic ovarian patient and going to cause more of the disease to happen. And the factors which are going to cause from the intrafollicular ovarian region is the follicular fluid factors, which are actually essential for folliculogenesis. And when these get affected, they're going to affect the growth of the follicles also. And the growth factors which are actually the intra-ovarian factors which are involved in polycystic ovarian disease are actually cytokines and inhibin, which have got a great role to play in the disease formation in polycystic ovarian disease. So what happens is the extra ovarian factors are from the pituitary and the hypothalamus. It's going to be a decreased FSH, increased LH, androgen which can be adrenal or ovarian origin, and the increase in insulin secretion. Intravariant factors are the growth factors, the cytokines, the homocysteine, leptin, and oxidative stress. And these are going to contribute to follicular alterations as well as the oocyte abnormalities. And that's why it contributes to a poor embryo quality. So there's an altered secretion of GnRH as well as gonadotropins in a polycystic ovarian patient. They tend to have an elevated LH FSH ratio. And that's basically not because it's more of a high level of LH compared to actually not a reduced production of FSH. FSH may be normally secreted, but LH will be high. And GnRH stimulation is the reason why there's an excessive LH production in PCOS women. And this they have attributed to a higher frequency or amplitude of GnRH. That is, they say that the gonad axis in the hypothalamus pituitary ovarian axis, which is being managed by the gonadal axis, they say that gets altered in a PCOS patient. So they'll have a higher frequency or an amplitude of the GnRH from the hypothalamus. It's going to act not on the FSH, which is more, FSH is actually dependent on estradiol for its secretion, but LH is dependent on GnRH. So when GnRH amplitude changes, the LH gets produced more. And there is no clarity of whether this alterations in the HPO axis in a polycystic ovarian patient is primary or secondary to alterations in the steroid hormone secretion from the ovary. So the basic factor is there will be increased LH, normal or low FSH, and the LH is because of increased amplitude and frequency of GnRH secretion from the hypothalamus. So what about FSH and estradiol? When you think about FSH, FSH is the hormone which is needed for the recruitment of the ovarian follicles in a cycle, and they will stimulate the growth of the follicles. And that's why these smaller follicles, the 2 to 5 mm size follicles, are always sensitive to FSH. But once they become bigger and they attain the size of 6 to 8 mm, they acquire aromatase activity and they will increase estradiol production and inhibin B. And once you have got estradiol and inhibin B in the circulation, that's going to reduce the level of FSH in the late follicular stage. And that's why 6 to 8 mm follicles, once they cross that and become dominant, they're going to stop the FSH from getting secreted so that no more follicles get recruited. And PCOS patients, when they have LH and FSH concentration is changed, that is LH is more and FSH is low or normal, they will accumulate the follicles to a size around 2 to 8 mm. That is, these will not respond to FSH and they just get arrested. And that is, they grow and then they undergo a premature growth arrest because LH is getting secreted more and it's not going to allow more growth of the follicles because FSH effect is not being taken up by the follicles. So the hypersecretion of LH will also promote the early luteinization of the granulosa cells, and that will also contribute to an early arrest of the antral follicles. Other than that, not only in the follicular growth, it's going to affect the oocyte also. That will activate the premature meiotic process in the oocyte, and that will damage oocyte quality and contribute to the formation of aneuploidies in the embryo. And that's why abortions are much more common, miscarriages are much more common in PCOS patients. So this is a picture which will clearly tell you, in a normal cycle, a follicle of 5 mm size will respond to FSH, will grow up to 10 mm. And then when it grows beyond that and estradiol gets secreted, it's going to reduce FSH and LH starts getting secreted to cause the ovulation. And LH will act when the follicle has reached 20 mm. But in an anovulatory cycle, like a PCOS patient, the follicles at 5 mm will respond to FSH, but now you've got LH also because there's a hypersecretion of LH in PCOS patients. And these follicles will not grow beyond 8 mm. They get stuck there because LH is added here and the differentiation does not happen. And that's why ovulation does not happen and they go for irregular cycles. And there's something called dopaminergic tone and opioid tone. They say that is also in PCOS patients. And when you give an antagonist, it actually not have any influence on LH pulsatility because it's gone beyond that. There's another group of hormones which they say has got an effect in a PCOS patient, and that is the kiss peptins. And they emerge as an essential upstream regulator of the GnRH neurons. They play a key role in reproduction, such as the brain sex differentiation, puberty onset, gonadotropin secretion, ovulation, and the metabolic regulation of fertility. And that is almost like it's a gonadostat. It is a one which makes the gonad function. And they are encoded by the KIS1 gene, and they operate to the G protein coupled receptor. And what happens to KIS1 in polycystic ovarian patients? It's because the ovarian expression is under the positive control of the gonad. The local mediators will control the expression of ovarian kiss peptin. And suppose you inhibit prostaglandin synthesis, it will suppress ovarian KIS1 mRNA levels, and that will cause ovarian dysfunction. And the inhibition will also block the positive effects of gonadotropin. What happens is when prostaglandin synthesis is inhibited, you're going to have a reduced kiss peptin levels. So these observations also suggest there's a potential role of locally produced kiss peptins controls of ovulation. And there are studies going on to find out whether the local actions of kiss peptins, when they're altered, may be the reason why ovulatory dysfunction happens in polycystic ovarian patients. They're trying to find out like the kiss peptins dysregulation in the ovary is a contributory factor for PCOS. And the other hormone which we need to always talk about, other than the central origin of the FSH levels and LH levels getting altered in PCOS, the other important hormone which changes in PCOS is androgens. It's typically elevated. And when you want to assess hyperandrogenism, you have to check for the total testosterone, free testosterone, sex hormone binding globulin, androstenedione, 17-hydroxyprogesterone, and DHEAs. All this you have to evaluate for a biochemical levels of androgen levels in the body. And it is secreted mostly by the ovaries. Most of the androgens are secreted mostly in the ovaries. And there's a substantial contribution from the adrenals, and there's a minor contribution from the fatty tissue also. So you've got the source of androgens are many: ovaries, adrenal, and the fatty tissue. And synthesis of androgen is actually mediated by microsomal P450C17, and this is catalyzed by one enzyme called 1720 lyase. In PCOS, there's an inhibition of 1720 lyase. This gets inhibited, but 17-hydroxylase does not get inhibited. So there's an increased 17-hydroxyprogesterone to androstenedione ratio, and there's an excess production of 17-hydroxyprogesterone. So this will tell us the cholesterol pathway. Cholesterol to pregnenolone, pregnenolone to 17-hydroxypregnenolone is with 17-alpha hydroxylase, and from pregnenolone to dehydroepiandrosterone, you need the enzyme 1720 lyase. So this gets blocked, but this does not get blocked much. So what happens, there's more production of 17-hydroxyprogesterone in this PCOS patients, and because 17-hydroxyprogesterone is more, it's going to actually reduce the activity of aromatase. So androgens are not converted to estrogens, and that's why you have more of androgens getting secreted in a polycystic ovarian patient. Estradiol will be normal because it's secreted by the granulosa cell, but you will have the other estrogens like which are getting converted in the fatty cells like estriol, which will be more. So you will have more of 17-hydroxyprogesterone and more of androgens, and because aromatase does not work much when this enzyme gets inhibited, and you will have more of androgens as well as 17-hydroxyprogesterone, which is going to be the substrate for the androgens. And also estradiol will be normal, but estriol will be high. So this is the pathway. Increase 17-hydroxyprogesterone because of the preferential blockage of the lyase enzyme will go on to cause a low aromatase activity. Aromatase is an enzyme which is needed for the conversion of androgens to estrogens. So when aromatase does not function well, you'll have more of androgens, and these androgens are going to have a negative impact locally in the ovary on follicular development, which will cause atresia, and on the oocyte development, it is going to cause a meiotic maturation inhibition, and that is because of the decreasing oscillation of the intracytoplasmic calcium levels. So the next hormone we need to talk about in polycystic ovarian disease after androgens is the insulin levels. There will be an increased insulin level in a PCOS patient, and there'll also be insulin resistance. Insulin resistance is a condition where the cell, tissue, or organism will require a higher level of insulin to respond normally. That is, they will have the receptors, but they will not respond to a normal level of insulin. They need higher number of insulin to function properly. And the tissues which need it is the muscles and the fat. So what happens is it causes an increase because the cells are resistant to insulin and they need more insulin. The pancreas responds by increasing insulin secretion. And that's why you'll have a hyperinsulinemia. Even though the cells do not take up the insulin and the glucose pathway does not work properly, they will have higher insulin levels along with higher glucose. And that's because of the resistance. And when the response of the pancreatic cells to this need for insulin decreases, what happens? The patient goes for type 2 diabetes because pancreas does not produce the required amount of insulin. So what happens to androgens in insulin resistance? The insulin resistance and because of the resistance, the compensatory hyperinsulinemia will cause hyperandrogenism because the insulin will go act on the ovary, because the insulin, the ovarian tissue is not resistant at all. It is a paradox. Other cells are resistant, but ovary is sensitive to the higher insulin. So what it does, it takes up more of the insulin. It's going to stimulate the ovary to produce more of androgens. And when insulin becomes higher, it's also inhibit the liver synthesis of sex hormone binding globulin. So what happens? The androgens are not bound and they become free, and that's why the testosterone availability becomes more. And because testosterone is more, they will manifest the features of hyperandrogenism in the form of hirsutism and acne. And the insulin will also go and act at the ACTH level, and that's going to cause an increase in the adrenal androgen production. And also this insulin will act on LH. Already LH is getting secreted more because of the GnRH, the amplitude and the frequency has changed. So LH is getting secreted more. And on top of that, the insulin also goes and acts. And what happens is LH increases more, and that's going to cause more of androgens from the ovary. So this is the pathway which we need to know. So LH is getting secreted more from the pituitary. It's going to act on the ovarian cells, and that is going to cause more of androgen production, as I said, because of the selective inhibition of lyase enzyme compared to hydroxylase. And insulin also will go and act on the same pathway, and it's going to increase the androgens from the ovary, and the production is going to become more and more. And you have to remember that not only obese patients with PCOS have insulin resistance, lean patients also can have, and that's why we need to check for glucose intolerance even in a person who's lean, which has got features of polycystic ovarian disease. And the mechanisms leading to insulin resistance in the other tissues is because there's a defect in the insulin binding to the receptor, or there's a change in the insulin signal transmission. But as I said, the ovaries of a polycystic ovarian patient are not insulin resistant. They actually have a normal response to insulin. That's because there's a different pathway here in the ovary compared to the other tissues. And that's because the action of insulin is through the insulin growth factor 1 receptor. And the binding occurs when insulin reaches high concentrations, as it happens in compensatory hyperinsulinemia. So the action of insulin in the ovary uses the inositol glycan system as a signal mediator. And that's a different mechanism from how the insulin acts in the other tissues, where it acts by phosphorylation of the receptor at tyrosine level. And they've observed an increase in the urinary clearance of inositol. That is, when the inositol pathway gets affected in a person with polycystic ovarian disease, and that's why giving the supplement actually helps a person who's got PCOS in the form of insulin sensitivity. So increasing the insulin sensitivity. And there's a decrease in the tissue availability of inositol in PCOS patients. And all these can contribute to insulin resistance, which is present in PCOS women. And it will directly stimulate the ovarian steroidogenesis by acting on the thecal and granulosa cells. There's an increase in secretion of androgens, and that's mediated by LH. And that's because LH will act on the cytochrome P450 sub-expression of LH and the IGF-1 receptor. It also influences the hyperandrogenism by inhibiting the liver synthesis of 6 hormone binding globulin and the insulin growth factor binding protein. That is, the binding protein reduces, and that's why IGF becomes more. And that is similar to insulin, and it will have a growth factor action. And IGF-1 is synthesized by the liver. It's also produced in other tissues, including the ovaries. And there's a significant increase in this ratio. That is the insulin growth factor 1 to the binding protein. The ratio is more towards the growth factor becoming more. And because of this increased availability of the growth factor in theca cells, it's going to cause an increased production of the androgens. And they not only stimulate the theca cells, they will stimulate the granulosa cells also. So that's why estrogen production also increases. And there's the modulation of the FSH and LH will get affected when estrogen production is also affected by this IGF-1. It will also affect the indirect control on the ovarian steroidogenesis through the hypothalamic pituitary axis too. So the other growth factors which we need to know, which is going to affect the ovulation as well as the follicular genesis and the steroid hormone production in the ovary. The other one are the epidermal growth factors. In the ovary, it is found in the follicular fluid, and it's supposed to regulate the follicle development and oocyte maturation. This epidermal growth factor is very important for regulation of cell growth as well as the proliferation differentiation through interaction with this receptor. In a polycystic ovarian patient, the epidermal growth factor in the follicular fluid is much higher, and that's why it may inhibit the granulosa cell estrogen synthesis, and that translates into an arrest of follicle growth. So basically, the hormones change not only in the extraovarian areas, that like the pituitary, the insulin production from the pancreas and the liver. It's going to affect from inside the ovary, and that is because of the growth factor changes. The other growth factor which can get affected in PCOS patient is the neurotropic growth factor, which is actually needed for the development of the nervous system, and it acts in the ovaries of both in all humans and mammals. It plays a very fundamental role in follicular genesis and oocyte maturation, and that's why when it gets elevated in the follicular fluid, when it gets elevated, it's going to cause more of a meiotic arrest in the oocytes in the form of a nuclear and cytoplasmic maturation arrest. And transforming growth factor beta is another group of hormones which get affected in polycystic ovarian patients. And the hormones which are there in this group is the anti-Mullerian hormone, activin, polystatin, inhibins, and bone morphogenetic protein and growth and differentiation factor. And in different occasions, these growth factors may promote or block follicle growth and differentiation. And regarding anti-Mullerian hormone, it is a hormone which is actually needed in male embryos for the inhibition of the development of the Mullerian ducts, and that's why it's called anti-Mullerian hormone. But in a lady, it is expressed in the granulosa cells, and it controls the formation of primary follicles and follicle recruitment by FSH, and that's why it plays a very important role in follicular genesis. In a person with PCOS who's got a higher serum concentration of AMH, it is going to correlate to a greater development, faster development of andro follicles, which get arrested and they do not grow further in a PCOS patient. And that's why it also correlates to an increase in the testosterone levels as well as LH concentrations. And it also calls an alteration in the oocyte maturation, and it's attributed to a low embryo quality. And elevated concentrations in PCOS, the patients are going to have immature oocytes, and that's why low fertilization rates are much more common in PCOS patients compared to women with endometriosis or pelvic adhesion. The other hormones from the transforming growth factor family are activin, follistin, and inhibin. Activin, follistin, and inhibin are polypeptides, and they are found in the ovarian follicular fluid. Polystatin is produced by the granulosa cells. It is also regulated by the autocrine paracrine action, and it's needed for cellular growth and differentiation. When there's an increase in polystatin levels, it can cause an arrest of follicle growth and reduce oocyte development. Activin is secreted by the smaller follicles. It is needed for increasing the granulosa cell response to FSH stimulation. It is actually will decrease androgen synthesis. In a person with PCOS, activin levels are lower compared to polystatin and inhibin. Inhibin is produced by the dominant follicle, will stimulate the theca cells to produce androgens as substrate for estrogen formation, and they inhibit FSH secretion. And in PCOS patient, you will have an increased polystatin activin ratio and an elevated inhibin B. Activin will be low, polystatin and inhibin will be higher in patients with polycystic ovarian disease. The other growth factor which you need to know is vascular endothelial growth factor, which is needed for angiogenesis, follicular vascularization, and intrafollicular oxygenation. It's got an impact of follicle maturation, oocyte quality, fertilization, and embryo development. The alterations, when you see them in polycystic ovarian patient, is indication of oocyte maturity as in the other growth factors. The other group which you need to know is the interleukins, and particularly the 1, 2, 6, 8, 11, 12, all play different roles in follicular genesis, ovulation, and corpus luteum formation. IL-2 will differ from immature follicles and those in the pre-ovulatory phase, and it is actually reduced. When you have an elevated concentration of IL-3, it correlates with PCOS, and when you have IL-13 more, it's going to cause a reduced oocyte maturation, fertilization, and subsequently a pregnancy. The other growth factor is a tumor necrosis factor, which has got an influence on maturation, steroidogenesis and apoptosis. It is expressed by the oocyte, the theca cells, granulosa cells, and corpus luteum. There's an alteration in the levels of this tumor necrosis factor. It's going to cause a poor oocyte quality. And when there's an increased concentration in a polycystic ovarian patient, it is going to indicate a poor oocyte and a poor embryo. And there's something called FAS and FAS ligand. They are membrane proteins which belong to the TNF subfamily, and they have an anti and a pro-apoptotic function. And when the concentrations of FAS in follicular fluid, it positively correlates with oocyte maturity. And they found out that when the PCOS patient is treated with metformin or any insulin sensitizer, there's a reduction in the follicular fluid concentration of FASL. And they say when FASL reduces, there's an increase in implantation and pregnancy percentages. And the other hormone which you need to know is vitamin D. And they found out that there's a vitamin D deficiency in patients with PCOS. And also when there's a vitamin D deficiency, there's an increased likelihood of developing metabolic disorders. And obese patients also have a lower serum level of vitamin D compared to non-obese patients. And they have a development in insulin resistance and impaired glucose tolerance. So this is called a multi-pronged action in the PCOS patient. So what are the implications of all these hormonal imbalances? There is an excessive androgen biosynthesis and secretion by the ovary, and there's a key pathogenetic mechanism of PCOS. That is, you have increased androgen production by the ovary, and any patient who is presenting with weight excess and is showing a hirsute feature, that is showing hyperandrogenic phenotype, please remember they are going to have more chance of having insulin resistance. And when insulin resistance happens along with its compensatory hyperinsulinism, it is further going to enhance ovarian and adrenal androgen secretion. And this androgen, when it becomes excess, it's going to cause more of visceral fat deposition, that is central fat deposition, and possibly there's a dysfunction of the adipocytes also. This will worsen the insulin resistance and hyperinsulinism. And that's why hyperandrogenism, dysfunctional adiposity, and insulin resistance contribute to an increased cardiometabolic risk in these women. So it starts from androgens, goes on to have more of insulin resistance. More of insulin resistance is going to cause more of visceral fat deposition, and more of visceral fat deposition is going to cause an increased cardiometabolic risk in these women. And that's why the pathway of PCOS is very dangerous. So I would like to conclude by saying that it's not only reproductive pathology, but it's also a systemic condition. And this etiopathy is still not completely understood, but we need to know that we need to improve our preventive strategies and also have a standard treatment for the disease. The two tools which are there for the management of this condition in a lady are hormonal contraceptives to stop the ovaries from producing more of androgens, give anti-androgen drugs, give insulin sensitizers like metformin and inositol so that you block the pathway somewhere. And early diagnosis and treatment in a PCOS patient will prevent or delay its typical long-term sequelae. Thank you so much for a patient here.
Thank you, ma'am. Thank you very much for that another wonderful learning presentation today, ma'am. You have taken us to the molecular level of this hormonal and insulin resistance, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am.
Yeah, no problem.
Queries and read out for you, ma'am. Ma'am, I have a query like whether in non-hyperandrogenic phenotypes, whether this DHEA can be recommended, ma'am. Low doses of DHEA.
Actually, DHEA is useful only when there is reduced oocyte quality or the patient is aging. So she will have a reduced oocyte number also. So maybe in them it will help. Do not give it for a PCOS patient because they already have enough of follicles there. It's not the follicle which is a problem. The numbers are not the problem. So giving DHEA for a PCOS patient is not advisable at this point of time.
During at the time of ovulation induction, it is not recommended, ma'am. DHEA.
Not for PCOS patient.
Not for PCOS.
You can give for the other patients because you can have an intra-ovarian activity. So it can cause an increase in the oocyte quality and probably help also. But there are no studies to say that it will help in a PCOS patient because already they have an increased androgen. So why do you want to give another androgen?
Yes. So participants, if you have any queries, you can just post it here so that I can read it for me. Ma'am, there is no other queries in the chat box, ma'am. So far, so
Oh,
if there is any queries, then we will mail you, ma'am. You can just
okay. Yeah, yeah. I will answer anything.
yeah.
Okay.
Thank you,
Thank
ma'am.
you.
Thank you very
Thank you.
much
Thank
for
you.
being with us and spending your valuable time with us today,
Yeah.
ma'am. And
Thank
also
you so much.
thank the participants for their active participation.
Yeah. Thank you. Thank you
Thank
so
you,
much.
thank you very much.
Thank you.